Yeah, so I'm talking about, yeah, you can the other one.
And you have videos.
Yeah, if you put it on the other one, that would be great. So I'm going to be talking today about high quality supportive critical care. So if you hit the next slide, Amir. So first we'll just discuss about what makes intensive care a different setting to the wards. And these are some of the things that I could think of when I was writing this topic. So we deal with very sick patients, far sicker than on the wards. We're doing invasive things to our patients. We're putting tubes in them, putting lines in them, all of which don't happen on wards downstairs. We take over a lot of the functioning of their body. We take over breathing for them. We take over their kidneys, and lots of them they don't move, whether they're intubated or otherwise. Even our ones that are extubated, they can be very frail, very deconditioned, and they aren't getting out of bed. So all of this means that we're dealing with in a different setting than we would do on a ward, which comes up with its own challenges. So next slide. So when we're thinking about high quality supportive critical care, we're basically trying to strike a balance between allowing the patient to recover from the illness that's brought them into the unit, whilst avoiding complications from these invasive sometimes quite nasty interventions that we're having to do. And I guess it sort of it's a balance between both of them, and a race between getting them fit enough before they start to accrue these complications. And I think we can all think of patients in our minds that sort of come to the forefront, people that just can't get off the unit because new problems keep coming up from things that we are doing to them. Yeah, next one. So this was sort of my definition that helped me think about high quality supportive care. The one thing that this talk isn't going to be is exciting. It's not going to be particularly flashy, but I think that's the whole point of it. It's doing the basics well, and when we upscale them to every patient that we see on the unit, every patient that comes through, we can end up making a big difference to our patients and hopefully improving their outcomes. And these are also sort of SHO level things that you might not want to go and bother the reg about at 4 a.m. or you might not want to call the boss. So it helps. It might help you guys to troubleshoot issues that nurses give you there and then on the spot. So if you go on the next slide. So these are some of the things that we're going to talk about. I think you'll agree that it's not very flashy, but if we can do these basic things well, then hopefully we'll improve our patient outcomes. So we'll quickly whiz through them because I can see some nodding heads. So DVT prophylaxis, I think actually now we're getting pretty good at. The drug charts make it very easy. It's on the front of it, you can't really miss it if you're clotting in a patient. Just be wary of some of the contraindications. And I think I've seen a couple of instances where patients have come up from maybe some of the medical wards where incorrect doses have been prescribed either by weight or by renal function. One springs to mind that I had on my last night where someone was given treatment dose dalteparin with an EGFR 20. They needed a VAS cath and it was a bloodbath. So this way, it can be important. The other thing just to bear in mind is if they're on a filter, whether they need to be on systemic anticoagulation for one reason or whether they need it just through the filter alone. GI prophylaxis, again, it's something that I think we're getting pretty good at. It's on the drug chart on the front, can't really miss it. Preventing ulcers in ICU, so there's non-pharmacological things we can do. Potentially, if someone's on 75 of aspirin and you can't really figure out why, you could potentially stop that for a short period whilst they're on. I think we all know to avoid NSAIDs because that can sort of precipitate this problem. And actually feeding them early has been shown to prevent stress ulcers. So getting an NG down, starting feeding if it's safe, will help to prevent this. Pharmacology, of course, it's omeprazole, lansoprazole. All intubated patients should be on them, and high-risk non-intubated patients. So we're talking about previous GI bleeds, if they're shocked, or if they're coagulopathic, don't hesitate to stick them on. And of course, patients on steroids as well, that should again trigger your mind to stick them on PPI. So anemia, HBs drift, HBs drop quite a lot on ICU, and I guess I found myself in the position where I think, oh God, shall I transfuse, shall I not? The reason why this can happen is hematopoiesis is suppressed when someone's critically ill, and there may be subclinical losses from the GI tract which aren't manifesting as large melenas, but still, because of the stress that patients are under, they may be having some of those losses. This graph on the right is just to show that, in the first 2 or 3 days, most ICU patients will tend to drop their HB by 10, well, not, sorry, yeah, by about 10 points. Septic patients can continue to drop their HB, but the ones that aren't septic, it does tend to level out after a while. So just remain vigilant to the fact that this can happen. Next slide. So, of course, if there's any acute drop in HB, any sudden deterioration, that needs to be thoroughly investigated. Do your PRs, look for melena, look for any hematemesis, any bleeding from anywhere else. And the way that we treat, obviously, final cause. And I think we want to do is start to move towards these conservative blood transfusions. This sort of topic's been out there for a while. I think, again, most of us are probably already doing this to an extent already, but we want to try and minimize the number of transfusions that we're giving, because transfusion reactions, pulmonary edema, febrile reactions, these are all things that we might not see that often, but they do crop up and they can cause problems. So always give 1 unit at a time and then reassess. These are the sort of transfusion targets that I think we're used to now, but they're not hard and fast. Someone having active melena, you may want to aim a little bit higher, but it's just it's just to get across that we don't want to be too judicious. Give someone 2 units too quickly, and then we have another problem, pulmonary edema, and that's not giving high quality supportive care. Next one. So blood sugars, again, another one. How often do we get called? Blood sugar 17 now. What do we do? Hyperglycemia and erratic BNs are associated with poor outcomes in patients with ICU, but it's quite difficult to establish causality and whether that in itself is causing harm, or whether these patients are generally a bit sicker. Their sugars are more deranged as a result of that. And that's what's causing these poor outcomes. The main thing that we want to do is avoid hyperglycemia. That's the thing that kills patients quickly. I'll just pop back 1 second, make sure I've said everything. But yeah, so no trial that I could find showed that treating hyperglycemia aggressively improves outcomes. But it's something that I think, the hospital protocol that we have does say that we should be monitoring our blood sugars in our patients. So now we can go to the next one. So this is straight off our intranet. So if you're clerking someone in at night and their blood sugars are 18, they're diabetic, you're not sure whether to start them on a sliding scale, just type in hyperglycemia on the intranet. Good little flow chart comes up. So these are some of the indications for which you might want to start a variable rate. Known diabetes. So particularly here, this severe illness with need to achieve good glycemic control. You could extrapolate that to quite a lot of patients that come through. So don't be afraid necessarily starting a variable rate if you need to. And this is just a copy of our typed glycemic control from our drug chart. You just circle one of them, sign it, and we'll do the rest. Early feeding, again, I think we've been drummed into us from the start that we need to be feeding all of our patients as soon as we can. The reason why that's beneficial is because you can prevent bacterial translocation from the gut, causing, making patients more septic. You can prevent ileus, prevent stress ulcers, all those things. Contraindications are reasonably self-explanatory. Anyone with a surgical abdomen, upper GI bleed, you want to just hold off a little bit. Next slide. So I guess it's just our job to be aware that this is something that we should be thinking of when a patient gets clerked in. The dietitians do a very good job of advising us about regimes and what feeds to start, etc. something I just thought about, again, often we get called about high Ng aspirates, what do we do, what do they mean? Initially, we were using them to guide us about whether a patient might be at risk of having an aspiration pneumonia. But now we tend to use them to identify patients that might be intolerant of their feed and may not be absorbing so much of their feed. High Ng aspirate is a sign of delayed gastric emptying, but the cutoff that we have of 500 mils is an arbitrary target. And a couple of trials that I was looking at showed that, so there was one in 2010, there was no difference between using a 500 mil cutoff and a 200 mil cutoff in terms of GI complications, so stress ulcers, upper GI bleeds, or ICU acquired pneumonias, given that we used to think that that might correlate to risk of aspiration. And another trial showed that there was no difference when you were looking at a 250 mil cutoff for an Ng aspirate, as opposed to none at all and not measuring it when looking at ventilator-associated pneumonias. So it's not an exact science, and sometimes you might get a one-off result, which then self-corrects by itself. And as I was saying, it's not the best predictor of risk of aspiration, but we still treat it because doctors, we like to intervene and treat. So we can give metoclopramide or erythromycin. Metoclopramide does have side effects. It's not something just to prescribe willy-nilly. It can cause these dystonic reactions. It can cause prolonged QT, and it can even contribute to raising intracranial pressure. So you've got to be a little bit mindful when you're prescribing it. Erythromycin, I read that actually it's slightly more effective than metoclopramide in terms of promoting sort of gastric motility, but it's a CYP450. It's metabolized by the CYP450, so any medications that they're on that's metabolized in that route is going to be a bit screwed up by erythromycin, so to be aware as well. Next one. Again, delirium. So lots of our patients will have delirium of some form, poor sleep, agitation, difficulty wheeling off the ventilator, very, very common. Important to realize that we can utilize non-pharmacological treatments and interventions, so giving patients earplugs, eye masks, try and promote good sleep hygiene, make sure that they're orientated frequently. Lots of patients say, where am I, what's the time? Make sure that you're reorientating them to try and help with this. Poor sleep, we can give melatonin. This site that I found, which was quite skewed to the US, says that we can use quetiapine. Make sure if you are going to use it, give it early in the night to prevent them from being too sleepy during the day. Read about potentially using a bit of nocturnal Dextor. I haven't seen that used too much here to try and sort out sleep problems. But if your patients are really struggling, it's something to maybe flag up to one of the regs. And again, agitation, we can use Dextor, particularly if they're coming off a ventilator. We can use haloperidol, just be aware of a long QT. But also, we try to avoid benders as much as we can. If patients are delirious, it might temporarily calm them, but you're not actually going to sort the problem out of their underlying delirium. If you need to go there and they're being too difficult to manage, I don't know, that's something I would probably chat to the bosses before I went ahead and prescribed it. Coming towards the end, guys, stay with me.
Next slide.
Yeah, yes, please, yeah. Fluids, my God, it is dry, isn't it? ICU patients often fluid overloaded, as we heard in the last talk. Aseptic, they often hold, they leak into the third space, but they keep hold of it. Doesn't help that we often, ED or medics, or else we chuck them full of fluid in their first 24 hours. So often they end up quite positive. Maintenance fluids, if you look at the input-output chart, lots of fluid goes in with the NG feed, lots goes in with their infusions and their medications. So it's something to, that should only really be done if you think they need it, or if it's involved in a certain protocol. So, for example, DKA, obviously you wouldn't omit it in that condition. keeping patients positive 1-2 litres over 4 or 5 days, that's not high quality supportive care. So if you need to utilise a bit of furosemide to try out, make sure that we're hitting their target balances, that can be done. But again, just watch out, that can cause its own problems. Lots of these things that I've been speaking about, interventions that we can use, have their own side effects and their own drawbacks. And I think that's the mainstay of supportive care, is that we need to balance between our interventions and our side effects to try and promote the best outcomes for our patients. Don't chase a high lactate or a low urine output with fluids unless your examination determines that you do so. So make sure that you're looking for fluid status. Give small boluses and then reevaluate. You can always give more, but unless they want to filter it, it can be difficult to take that off. Had quite a lot of teaching on lidcos recently on the ward rounds. Some consultants like it, some don't. I got burnt on one night shift relying too much on the lidco with a patient who had a crappy ejection fraction. I thought, oh, the lidco's telling me I can give fluid, I'll give some, and she went into pulmonary edema. So again, don't use it as part of your toolbox to guide fluid status and not to be too heavily reliant on it. And of course, I can't remember the last time I saw someone have normal saline in the ICU, but it's been generically binned because it can cause dilutional acidosis and can sometimes promote put someone into renal failure as well. I think we're coming towards the end now. Got a little bit more to go. Again, you guys all know temp spikes should be taken seriously on the ICU. About half are caused by an infection, whether it's their cat that's brought them in or a line infection or something else. But there can be temp spikes that aren't coming from an actual infection, whether it's something sterile like pancreatitis, whether it's an indication of something else going on like a transfusion reaction or alcohol withdrawal. But it's good to be prudent, take it seriously, work them up, get the cultures done, get the x-ray. Again, just do the basic things well. Next one. Yeah, it's not just doctors that have a role to play in supportive care. There's the MDT, has a role to play as well. Really, our chest physio, our physios do a wonderful job promoting clearance, shifting mucus and secretions to improve people who might have lung collapse, atelectasis, and getting patients out of bed ASAP has been shown to improve outcomes. The nurses do a good job as well, repositioning in bed, avoiding pressure sores, suctioning as well, and eye and mouth care, and psychologists to help with patients who are having anxiety about their ICU stay. And again, I think we can all think of patients who just are down in the dumps about being on ICU for weeks and weeks and nothing happening. And it's up to us to maybe, because we're the only ones spending a lot of time with our patients, we should think about that and get on the phone to Hannah, who can come and have a chat to them. It's all about promoting, holistic good care of our patients. So just thought we'd finish with that. I think that's it really. Just reiterate this message again, that we want to put our patients in the best place to recover from their illness whilst dodging the myriad obstacles and opportunities for complications that can crop up. Basics, just do the basic things well. On our blue sheets, that flat hugs mnemonic at the back, hidden away in a corner, but that's got most of this stuff on it. Don't neglect it, use it. You might pick up on something that your colleagues might have missed, the nurses might have missed, and that can make a big difference to our patients. That's it. Not the most exciting topic, but do the basics well. Yeah.
Thank you. Any doubts, any questions?
I'd just like to reiterate what you just said, because whether following me or following my colleagues on the wall, and the secret of moving patients from A to B, especially if they are long-term patients, lies in this, the small details, whether you prescribe this and that, whether you find out that the patient is left without an engine tube for 5 days. Why? Because nobody could put one in, or we just left it as it is. If you don't do the basic little things, patients will not progress whatsoever. You need to find out if the patient is anxious. You need to find out Have you ever thought about how bad is it to have an NG tube in somebody? If okay, we have an arbitrary, in our unit, the arbitrary cutoff is 350 mils, for example, for aspiration. So if they don't check it, or if they would ignore it, they should probably drown in their own secretions or undigested food and so on. So accepting the lower hemoglobin targets. We, as well as ICU consultant, we had to learn that we shouldn't, go for transfusion straight away. 7, 8 on the filter, accept lower blood pressure. Try to see and look into the details. I think that's one of the key, what you just said, to progress and make difference day to day. And I'm also emphasizing you when you see long-term patients, just don't drop your guides. Check everything, and this is how you're going to make them up. Your ultimate goal is to get them out from the unit, hopefully with a good outcome. Thank you very much. It was very good.
Dr. Ferrick, I have one doubt for you. Do we have a dedicated ICNR nurse over here? The one who measures the ICNR scoring?
I think we do.
What's that, sorry? The
Every unit has to have one. We have to have one. Yes, knows actually.
what is that, sorry?
So ICNR is stands for Intensive Care Network Annual Review Council. Okay. So this is like a nationalized network wherein they collect data from all the intensive care, and they have created a complex protocol or a scoring system. So it does actually help the consultants decide upon what will be the outcome of the patients, and at the same time, like what are the possible complications or morbidities we will be anticipating within the ICU. Okay? So in a way that actually helps us to know whether this patient is going to come to the ICU or going to stay in the ICU for a longer time or not. In fact, every year ICNR sends out its data, and based on that they give a lot of predictive pointers. Like, can we find out whether this patient can, certain subset of patients, whether they can develop pulmonary or cerebral complications or not. Then we also would like to know the level of care as well. So whether a patient should stay in ICU, yes or no, is also one question. So if he is not going to stay in ICU, is he a good candidate for ward or HD, or can he go home? This is based on the level of care. Again, within the wards, we are measuring early warning system, scoring system, which is also called as a new score. New score also helps us tell who should actually do the care. Is it the ward-based care or is it the ITU-based care that we should be giving? And these three parameters you should also keep into mind along with whatever you have presented. Because this also helps in not only preventing mortality or rather reducing the mortality, but at the same time it also helps in providing a good satisfactory, good patient satisfaction, I would say. So anything from the other side of the computer, do you have any doubts for Jay? So I believe no doubts. Thank you everyone.